Welcome back to today's FAQ, where we bring rheumatology education directly to APPs caring for patients every day. Today, I'm your host, Audrey Gibson. I'm a physician assistant from the Arthritis Center of North Georgia in Gainesville, Georgia. And today we're tackling an important question. What are the key unmet needs in the treatment of idiopathic inflammatory myopathies? Idiopathic inflammatory myopathies are among the most challenging diseases we manage in rheumatology. These conditions are rare, heterogeneous, multi-system, and often difficult to diagnose and treat. And despite advances in immunology and targeted therapies, many patients still experience delayed diagnosis, inadequate disease control, disability, or treatment-related toxicity. So today, let's break into this clinically relevant themes that we can apply in everyday practice. I think one of the biggest unmet needs is simply just recognizing how diverse these diseases truly are. Unfortunately, myositis diagnosis is still often delayed and difficult to diagnose. Patients often go months, some even years, before receiving the correct diagnosis. And one of the big reasons that this happens is because the presentation is often subtle or atypical. Not every patient walks in with classic proximal muscle weakness or a heliotrope rash. And unfortunately, delays in diagnosis can have major consequences. So one unmet need is better awareness and earlier recognition. In practice, that means maintaining a high index of suspicion with patients with unexplained weakness, elevated muscle enzymes, inflammatory rashes, or ILD plus autoimmune features, especially when those symptoms don't fit neatly into another diagnosis category. Another challenge can be the lack of standardized treatment algorithms. Treatment approaches are still very highly variable. Unlike rheumatoid arthritis, where we have well-established treat-to-target models, myositis management is often based on small studies, expert opinions, retrospective data, and clinical experience. One other unmet need is that steroids are still the backbone of initial therapy for many patients, but long-term steroid toxicity can have negative impact on patients, including diabetes, osteoporosis, weight gain, hypertension, and increased risk for infection, and even can cause muscle damage from chronic steroid exposure itself. So we urgently need more effective steroid-sparing therapies. And while agents like IVIG, rituximab, mycophenolate, JAK inhibitors, and FcRn inhibitors under investigation are helping to expand our options, we still lack clear evidence-based sequencing strategies. Furthermore, the disease exhibits significant heterogeneity. Not all myositis behaves the same. For example, a patient with anti-Mi2 dermatomyositis may respond very differently than a patient with anti-SRP necrotizing myopathy or anti-MDA5 disease. The antibody profile increasingly guides prognosis and management, but there are still gaps in how we personalize our care. We're moving toward more precision medicine in myositis, but we're not fully there yet. There is still a major unmet need for better biomarkers, better predictors of treatment response, and better risk stratification tools. Lastly, we need more targeted therapies. Historically, many treatments have been borrowed from other autoimmune diseases. Exciting areas of research now include FcRn blockade, interferon pathway inhibition, JAK inhibition, complement-targeted therapies, and other precision immunologic approaches. This is especially promising because we're beginning to better understand the specific pathways driving disease in different myositis subsets. The future of treatment will likely become far more personalized. So when we take a step back and we ask ourselves, what are the biggest unmet needs in idiopathic inflammatory myopathies? The answer really includes several major themes: earlier diagnosis, better biomarkers, more standardized treatment pathways, improved steroid-sparing strategies, and a development of targeted therapies. We often serve as the clinicians who identify subtle disease progression, coordinates multidisciplinary care, monitors treatment toxicity, educates patients, and assists in managing and long-term functional impact of these diseases. And as new therapies emerge, APPs will continue to play a central role in translating evolving science into practical patient care. So thanks for joining me in today's FAQ. If you would like additional information, please visit the Content Room or the WrapAce app or the WrAP website. Thanks for listening.